Now, hip preservation has been the human need since ages. We all know it. The field of non-orthoplastic surgical treatment of the adult hip is increasingly being referred to as hip preservation surgery. And these are the various day-to-day activities for which the hip is involved, like sitting on chairs, squatting toes. And these are the wonders of hip. Amazing range of motion that a natural hip can provide, what a versatile joint it is God has given us. And there is no material and no implant that is so versatile in its function that lasts the whole life as man's own native hip. And we all agree that patient's own viable hip lasts the whole life. Why not preserve it? These are the various conditions that result in arthritis, traumatic slip, Pathologies, dysplasia, infection, coxa vara. Arthritis is primary, secondary in my country, in primary in your country. Today we have better infrastructure, better techniques, research facilities. So we should work on hip preservation treatment modalities. The treatment ranges from isolated arthroscopic procedures like we repair the labral tears, open procedure, or hybrid. We can combine both. These are some of the procedures, again, debridement, repair of the torn labrum, cartilage defects, mostly knee we are practicing, but hip too. And some osteotomies we have been discussing since morning, both acetabular or innominate osteotomies and proximal femoral osteotomies. These can be combined with other procedures like arthroscopy also. And we have special MRI techniques, particularly OCT, when we can see the degenerative change of the cartilage with arthroscope. And we have procedures when cartilage is healthy, what to do. Procedures may be done when hip doesn't show significant degenerative changes, or when significant degenerative changes are there. This is slip, done 13 years back, reduction and pinning, there is a cam-like lesion. Now this patient cannot squat comfortably in external rotation, the essential movements of our patients in third world countries. So I think a valgus osteotomy is a better choice. We can correct the anatomy and biomechanics to balance the body liver arm, the muscular liver arm, to have a good function. And osteotomies have been talked to you. Coxa valga. I don't know it is healed Pathologies or because this is bump of bone. Patient cannot squat on hips in external rotation. So I did just the rotational osteotomy and gave him the full function. But 10 years later, some changes are there. And this sigmoid bump, the cam-like lesions. So here one could do open reduction. Arthroscopy I don't think has any role. Surgical dislocation and remove this bump and give him again function. He has gained his abduction, you can see frog-leg view also. And his function is restored to near normal. OA changes, this is Bombelli's concept, that the roof osteophytes can be exploited. In my hand, this patient had result of 14 years, 6 months, and the function the same as of hip, painless. This osteotomy was done in 1990 by one of my seniors, 91. So he had arthritic changes. It lasted 16 years. So I revised the osteotomy, just 10-degree exercise wedge, changed the articular motion, and found that this lasted till he died. Coxa vara on this side, marriageable age, young girl, 20 years old, 110 this side, 130 this side. I just did a valgus osteotomy with lateralization of the distal fragment, and this is the wedge of bone, and she had normal gait. Now this is pathologic fracture, secondary to fibrous dysplasia. The standard convention treatment is curettage bone grafting. See so many series. We et al., she et al., Gully et al. I just did osteotomy. No curettage, no bone grafting. It's healed. And 280 weeks follow-up is published in CORR 437 by Magu et al. And I presented this paper in CCOT oral presentation 2011. This is 12 years now after the publication and excellent range of motion. Why arthroplasty or the procedures? Ipsilateral fibrous dysplasia, see, elim is involved, healed excellently. I have done 12 cases now, 97, this is 14 years. There's complete healing, no pain, fracture is healed. Albert's disease, bilateral fracture, just osteotomy, works very well. Simple bone cyst, this lesion was missed if you see this X-ray. And we were doing a thesis on valgus osteotomy in osteoporotic femoral neck fractures, and we found it later on, it healed. No interposition, no injection, no curettage, and that is at range of motion, and this is 20 years. Just an osteotomy, average follow-up 171 months. For that case, the longest follow-up 234 weeks. Fibrous dysplasia 218 weeks. Some cases of giant cell also. So sound healing of lesion and the fracture and the osteotomy can be achieved in pathologic fractures secondary to simple bone cyst and fibrous dysplasia just with osteotomy, no curettage, no bone grafting. Giant cell tumor in the wall of anal bone cyst. Advised THR everywhere. 20 years female. Osteosynthesis done somewhere, failed. You see the CT section. Here I have done the curettage, bone grafting, fibrotic grafting, and osteotomy. Because osteotomy gives stability. It gives buttresses from below. And valgus reduction is also good for stability. You find some avian changes. This is 13 years, no recurrence. And I removed the implant in 2016, last year. This too is giant cell tumor. No bone is left. See the sections. Question of stability, very difficult. I curettage, did grafting, and jammed the blade into the acetabulum. My patients accept it, your patient may not accept it. And gave spica because it could be painful. And then remove the spica, and to protect the healing of osteotomy and fracture, I did this contour plating. 56 weeks, and 312 weeks follow-up was presented in CCOT, Gothenburg meeting, as a oral presentation. Range of motion, good, but not full. In her day-to-day activities, she is married now. She has 2 children. And this is the last follow-up, 12 years, no recurrence. So giant cell tumor with a large cystic component and a small area solid GC with no sarcomatous change may be ideally suited for curettage bone grafting and Powell's endotoxic osteotomy. No arthroplasty. Infection, local recurrence, refracture, femoral neck deformity, not seen. Osteonecrosis now I've seen in one case, I have shown you. Donor side morbidity, risk of infectious diseases transmission. All these things cannot be seen from when you don't use graft. Osteotomy has a biological role in the healing of the fracture itself, as well as the lesion, and this is published in CORR. I am showing you extended follow-up now. Avascular necrosis we come across, we are afraid of, scared of, and we go for THR. Yes, we should do it when indicated. These are some of the methods of management of avascular necrosis. Osteotomy is one, percutaneous multiple drilling, light bulb technique, trapdoor, all those techniques. And now it's being talked that if you through a window put BMP and bisphosphonates, this prevents the collapse of the head of the femur. I was talking to Kang yesterday. Core decompression, stage 1 of doctor. 11 years follow-up, you see this. It's healed. You see the pin site of decompression. So then osteotomy converts the location of a necrotic lesion medially or laterally, and the weight-bearing forces are transmitted through the living healthy bone. That's the principle. We can do valgus osteotomy, varus osteotomy, derotation osteotomy. So many osteotomies are being done. Can be prolonged even if it doesn't last the whole life. THR can be done in appropriate time. Patient was on bisphosphonates in AIMS. Regularly taking or not, I don't know. This is the healthy area. And a varus osteotomy is a good indication for such a patient. Bring the healthy cartilage under the weight-bearing dome. This case initially done by Joel Mata, then by Helfet, came to me with valgus hip, avascular necrosis. His problem was that he cannot sit comfortably in car. Flexion is limited. And this is good indication of varus osteotomy. THR can be done later on. Coxa valga with avascular necrosis in my hands. I did osteotomy, but patient cannot squat on cross legs. So I did the varus osteotomy. This is the osteotomy. This is 231 weeks. And this is 20 years. He has shortening of 2 centimeters, of course, but he is pain-free, and the avian changes have settled. That the spherolateral and posterior surfaces of the femoral head remain normal. And good results can be obtained in 83% of the patients after a varus flexion osteotomy. Avascular necrosis after femoral neck fixation, crescent sign you find here. This is the normal cartilage. CT. I remove the screw and put this fibula here, just 2 centimeters, to support the articular cartilage. It has healed. Plate is here. 385 weeks, see in CT section. This is not regular, but cartilage is living. This is the fibula. Full range of motion. 10 years follow-up. He has no problem. But here, this is different situation. Crescent sign. I put fibula, but only up to this place. So stability is a matter. It is just comparison. I was doing it. So this is collapsed. Fibula is up to this place. He has only limitation of external rotation. Even if this much kind of function you can achieve, I tell you, you cannot have this much function with THR. He is a student of St. Stephen, a very popular institution of the country. I was talking to Sandeep Madan. This is the latest. Should I remove this cam-like lesion to give him near normal abduction? But I'm scared. It might be contributing something to the vascularity of the head of the femur. Though valgus osteotomy will give a congruous normal hip. I am sure of that. And this much of function is far better than a THR, and our patients accept it. This is vascular fibrosis graft. People say 100% union and corrects or prevents avascular necrosis, done by one of my friend in Jaipur. There is collapse. I think so, because fibula should have been supporting the defect earlier. Now we see all these. Here it is supporting the necrotic areas, almost removed with reaming, and then you put this bone. I don't know it's provides stem cell or not. I'm not. There is no research. Here it is short, so there is collapse. In vascular fibrosis graft also, there is no support to this necrotic zone. It has not been removed also. So I think stability is very important. Of course, this may provide the biology. 1986, osteotomy done. It is a high mechanism osteotomy. John and Lahoti were talking to me. They were after me yesterday evening. Is Lahoti here or gone? He is gone. This is the healed. Coxa vera. Trochanter is elevated, gone up. Some more surgery was done. The acetabulo-trochanteric distance is reduced. He has shortening. And third procedure, fourth procedure, some kind of plating done somewhere, I don't know what's that, which you find here. So now the neck is short. There are OA changes. Trochanter is just touching the ilium. He has both painful and telgic and the Trendelenburg gait. I have not done any magic. Only a valgus osteotomy and lateralization of trochanter, and the wedge which I excised, I kept it in the elbow of the implant. 3.5 years, good neck is formed. Full flexion, no limp, why THR? I'm not against THR. 10 years. I call it a parrot beak, neck and head, like parrot beak. I received this. Neck is lengthened, neck shaft angle is restored, weight bearing area is enhanced, body lever arm and muscular lever arm balanced, no magic, just 30-degree excision of wedge and lateralization. I reduced it in the contours of the normal hip, this drawing, to have a near normal limb length. Normal limb. Some external rotation in cross-leg position is reduced only. It's normal function after 14 years. And I tell you, this is after 14 years. This is going to last the whole life. Not that I have done it. See the weight bearing area. And if there are significant OA changes, I will possibly go for a THR. Coxa vera, ATD ratio reversed, it is elevated. I did lateralization and valgus osteotomy. Patient not happy. Of course, because did not touch the trochanter. So she still had Trendelenburg gait. Once it healed, I removed the implant and put a fibula in the defect and did the lateralization of trochanter. And very interestingly, the patient told me post-operatively when she was in the bed, sir, now I am okay. Probably some proprioceptive sensations are transmitted when I did the lateral shoulder cancer, that this itself gave a feeling of well-being to the patient. And now it is okay. ATD ratio is restored. Body liver arm and muscular liver arm restored. There was some infection, superficial, which we healed. This is 10 years, joint space is good. 14 years, I called her. Let's pray it lasts. Healed tuberculosis, 2000, 2001. Coxa breva. There's no neck. Trochanter touching the ilium. I did osteotomy and combined it with distalization and lateral trochanter. The graft which I took from here, put it here, so that was distalized. The trochanter was distalized to give him neck length. So neck length is gained. This is the trochanter being brought down with tension band, and then a hole is slit, and through this, the blade is inserted into the neck. Excellent weight bearing area. Looks subluxated, but that is the shape of the head. Good range of motion. This is tight angle Achilles, corrected with time. And this is my test which I perform peroperatively. I make the position of 4 if he can. It means he can sit cross leg. 5 years. Healed infection again here. I did the osteotomy, valgus. Did very well. 30 years female, neglected slip, bilateral, painful, very painful, moved from place to place. You need special stem. She was refused THR also. Married. Her sister also had some kind of dysplasia for which 30 years back valgus osteotomy was done. And I was not willing to touch it. I didn't know whether the head is mobile or not. Functional excellent abduction, almost neutral, no abduction. Good range of adduction, but one doesn't know whether the movement is occurring at the head sternal junction or at the slip side. So I put wires and tested under the image. See, head could be mobilized. I just excise a wedge and medialize it. It supported the slip side. You find head is rotated. It has gone up. And graft is kept here. This plate is contoured. This is healed. Head is buttressed. So antalgic and tenement gate gone. She could not walk. And this was the problem for her since many months. Her married life was affected. I just took the patient in confidence. But maybe you get some relief. The other side also done. Range of abduction is increased. And this is after first surgery. No support. Leg length discrepancy is there because on the side of valgus osteotomy, the limb is lengthened. No pain. Tuberculosis again. Functional x-rays. Excessive adduction. See this. Much more than above the middle third of the thigh. Abductions limited. Stress area, osteophyte formation. She studies in an engineering college. Cannot squat. See how she is walking? Tight tendo Achilles, There is knee thrust. Milind Chaudhary shows sometimes the thrust in his knee injury cases. Milind. And how she squats. It is very difficult for her to perform her morning day-to-day activities. And she was in third year engineering college. I have not done any magic. I have only done valgus osteotomy, lateralization and derotation, that the patella faces the roof. She is happy. She can perform her all near normal activities. She is married. It's considered a very awkward posture as far as our society is concerned, particularly for a girl, marriageable. And now she has a near normal gait. She can sit cross-legged and happy. Just osteotomy, derotation, lateralization. It's 160 weeks. And now the latest follow-up, 325 weeks. It's Yoga Day worldwide. And hip is very important if you want to perform yoga. Preserve this amazing range of motion which you can do, proximal or combined. Pelvic osteotomy means your own hip lasts the whole life. AVN is no threat to painful condition. With AVN also you can have better range than a THR can provide. This is septic hip. My resident did IND and removed this sequestrum. A stump is left. I forgot. After 8 years, a good head is formed. So learning from child, learning from your experience. Some stem cells there, some growth plate is still there. And I did the valgus osteotomy with lateration and lengthening to give her equal limb length. With better facilities, research facilities, with better infrastructure. Now this is OCT, you can see arthroscopically what is claimed, the fissures in the articular cartilage using this MR technique. We are doing research on cartilage regeneration. There are insulin-like growth factors. You can all going on. Thank you very much.